Good evening, everyone. The White Army is privileged to have Dr.SR Chandra ma'am, retired professor from NIMHANS, as the moderator for today's case presentation. Welcome to you, ma'am. Dr.Anna from second year postgraduate
Thank
from
you.
Warangal Medical College has volunteered to present a neurological case. Welcome to you. With mentor's permission, we shall start the session.
Yes, ma. Start.
Good evening, ma'am.
Good evening.
My name is Anna. I'm a second year postgraduate from Kakatiya Medical College, Warangal.
Very good. Second year is now.
Hello, ma'am. Yes, ma'am.
Medicine.
Yes, ma'am. General medicine.
Okay.
A patient named by XYZ, 60-year-old male, with he's a farmer by occupation and he resides at Warangal. He himself is an informant along with his wife, and history is reliable. Came to the hospital with the chief complaints of difficulty in sitting down and getting up from squatting since 1 year, and history of syncopal attacks since 6 months, and the history of double vision of far objects since 3 months, ma'am. History of present illness. Patient was apparently asymptomatic and was performing his daily routine activities 1 year ago. Then he noticed difficulty in getting up from squatting and also sitting down. He noticed difficulty in slowness in doing activities, and he had difficulty in flexing of his upper limb and along lower limb while eating food or doing his activities. And he has stiffness of initially he had stiffness of lower limbs which progressed to upper limbs, ma'am. And he had difficulty in climbing stairs since 3 months. And tightness and stiffness of limbs is more in the right upper limb and lower limb, ma'am. And he has difficulty in walking since 1 year. He has difficulty in initiating the walking, and he is taking short steps, slow steps while walking. And he has difficulty in turning while walking. He is afraid that he'll fall while walking, ma'am. And he has difficulty in climbing stairs. History of difficulty in climbing stairs more than getting down from stairs. And he has history of loss of arm swing while walking. And now he has difficulty in getting up from bed also, ma'am. He is taking support of his attenders while getting up from bed since 3 months. And he had a history of syncopal attacks in 6 months. The syncopal attacks are more prominent while he is performing any activity, and no history of giddiness or palpitations, ma'am. He has multiple history of falls since 6 months, and 15 days ago also he had a history of fall with no loss of consciousness. But he got, with the support of others, he got up, and he had a head injury for which he had a laceration, and he got sutured, ma'am. And history of tingling sensation of right upper limb and lower limb since 6 months, ma'am. And he has a history of slurring of speech since 6 months ago, and history of deviation of mouth to left 6 months ago. And he had a history of double vision of far objects since 3 months, associated with blurred vision. And no history of buckling episode, and no history of increased salivation, loss of speech and constipation, no history of tremors, No issue of increase in frequency of micturition, volume, reduced sensation or fullness. No issue of increased sweating. No issue of difficulty in swallowing and speaking. And no issue of swaying while walking. And his personal history predominantly is vegetarian diet and no loss of appetite, bowel and bladder regular. His sleep is reduced and he has difficulty and no issue of smoking and ethanol consumption. Family history, no significant family history. Drug history, no issue of chronic drug abuse, ma'am. And past history, patient was operated for cataract in the left eye 2 years ago. And patient was not a known case of hypertension or diabetes. Summary, ma'am. Elderly male.
Okay. Now this is you have finished examination also. No.
No, ma'am. Just
Only history, no.
Yes, ma'am.
No, because we cannot say gaze palsy and other things, no. From the history, you will not diagnose gaze palsy in this case. Why, you tell me? Because you have written gaze palsy, no?
Yes, ma'am.
From the history, you will not know gaze palsy is there or not. And still you have written vertical gaze palsy. But one finding you told is very much against gaze palsy. What is that against? So from the history, without any clue, you should not tell vertical gaze palsy, no? Double vision, no?
Yes, ma'am.
Double vision will never occur in supranuclear pathology. Supranuclear pathology, what is the only situation where you can get double vision? Skew deviation. Skew deviation is vertical disconjugation of the eyes due to a supranuclear cause, where there is one eye will be up and another eye will be down, and that can produce a double vision, which is vertical, not for far off objects. And the double vision remains constant in all planes of eye movement. That way it is different from an element palsy.
Okay.
So I don't know how you got the clue from the history vertical gaze palsy and you told a double vision for a distant object. So that is not a match. Okay, now you told me that patient has difficulty in getting up and sitting down. No? What is the difficulty? Is it pain or is it stiffness or is it dropping of the hip or what is the difficulty? In getting up, what is the difficulty? In sitting down, what is the difficulty?
He had stiffness of limbs, ma'am. He can't flex his limbs and extend, ma'am. That is what is difficult.
Okay. So you should tell that it is a stiffness, no?
Yes.
And it started in the lower limb.
Yes, ma'am. Initially lower limbs, then progress to upper limbs, ma'am. So
he did not have any pain. So generally when somebody says difficulty in getting up and sitting down, I have discussed this many times. First you should tell about like painful, limb being short limb, no?
Yes, ma'am.
All those things are not there means you should tell whether it is distal weakness, proximal weakness, climbing up, climbing down, all those things. I am not going into that because we have discussed that many times. So now it is a stiffness.
Yes, ma'am.
So if the limb, lower limb onset stiffness, what are all the possibilities you will consider? If the limb is stiff, no?
Yes, ma'am.
What are all the structures? It could be pyramidal tract or it could be extrapyramidal tract. No? Yes. So stiffness has to be UMN only if it is painless. If it is painful, it could be joints.
Yes, ma'am.
If it is painless, it has to be upper motor neuron. In the upper motor neuron, it could be pyramidal or extrapyramidal.
Yes, ma'am.
So how do you know it is pyramidal? What other points you will ask to know whether the stiffness is due to pyramidal weakness? Pyramidal weakness, you have both kinetic melody. So the finest movements, approximating chapels into the feet, holding on and walking, and using gripping of the pen, type piano movement, musical instrument playing, or any fine movement which he has been doing. So it will be finest movement. It depends on the coarse versus fine. So pyramidal is the kinetic melody. So kinetic melody is most important for most precise movements. So it will be manifest distally, most manifest distally. Second, if the upper limbs are also involved, sometimes you may have the pyramidal pattern. Extension of the lower limbs is stronger and flexion of the upper limb is stronger. So whether the person has got fine movement impairment more than coarse movement. And second, is there any pyramidal pattern? Then when you are climbing up, getting down, sitting, so both climbing up and climbing down are weak or not. So these points will help. It may be pyramidal. Extrapyramidal is the weakness, difficulty is not due to kinetic melody. In extrapyramidal disorders, the problem is due to slowness. So it's a hypokinesia or bradykinesia. Because of the slowness, usually the patient manifests like a low backache, or it is like a periarthritis shoulder. So they will get treated as lumbar spondylosis, cervical spondylosis, periarthritis. So it has got nothing to do with the fineness of the movement. It is slowness. Whereas pyramidal is fineness. So because of the fineness, the kinetic melody is most involved in the distal most part of the limbs which carry out the fine movements, typewriting movement, piano playing movement. So that will be the pyramidal pattern. Whereas extrapyramidal is not due to kinetic melody, it is due to slowness. And that slowness will fix the joints. So usually patients end up with the orthopedic consultation for a long time. So that point you will ask. Then the pyramidal pattern will not be there. Extrapyramidal pattern will be there. Slowness, stiffness, altered posture, tendency to fall. So it may be UMN or LMN. So at this point, you can tell me it has to be UMN, pyramidal or extrapyramidal. Pyramidal, we know it is all corticospinal tracts, no? Which originate from the pyramidal cells in the cortex. Would you like to tell me what are all the structures which constitute the extrapyramidal system?
Basal ganglia.
Yes. What are they? What is basal ganglia? So the extrapyramidal means all the motor pathways which are not coming from the pyramidal neurons. You see, pyramidal neurons of the cerebral cortex give rise to some motor pathways. They are called as the pyramidal tract. And they form the pyramids in the medulla. Whereas extrapyramidal is all the motor pathways which originate from the non-pyramidal cells in the cortex. That is extrapyramidal. And what are all the structures which constitute the extrapyramidal system? Would you like to enumerate?
Basal ganglia.
What is basal ganglia? What is basal ganglia? What constitutes the basal ganglia?
Globus pallidus,
Yes.
and interna, and
Very good.
putamen.
Yes. Very good.
And subthalamus.
Yes, very good.
And midbrain red nucleus.
Very good.
And inferior olivary nucleus.
So extrapyramidal system mainly is constituted by striatum. Striatum is caudate nucleus and putamen. Second, pallidum. Pallidum is globus pallidus interna and globus pallidus externa. Third is substantia nigra, pars compacta and pars reticularis and subthalamic nucleus. These are the main components. That is, if you are asked, you should tell striatum, pallidum, then substantia nigra, pars compacta, reticulata and subthalamic nucleus. These are the main components of the extrapyramidal system. So what is the problem? You are getting all the structures which are motor but not originating from the pyramidal cells are extrapyramidal, I told.
Yes.
So that is a misnomer because you are having so many other systems like cerebellum. No, cerebellum is also a motor pathway which is not coming from the pyramidal system. And you have got vestibulospinal, reticulospinal, rubrospinal tracts. So they are all also non-pyramidal only, but they are not labeled extrapyramidal. By convention, it is striatum, pallidum, substantia nigra, pars compacta, pars reticularis and subthalamic nucleus and its connections. Okay. So So even though we call extrapyramidal, all motor pathways other than pyramidal, many of them are not really included. Thalamus, they are all sensory motor. Many of them are not included under extrapyramidal. So, so you have to ask your patient had stiffness in the back, in the shoulders. So lower limb onset, was it distal or proximal? Did you have any dystonias? So all those things will favor extrapyramidal. Or if he says only approximating the chapels into the feet, holding on, walking and removing the chapel was very difficult, but I did not have any back pain, I was not bent in posture, I did not have any dystonia, we will consider whether it is a pyramidal. So now we do not know. So he had difficulty due to stiffness. It may be pyramidal or extrapyramidal. We'll keep it like that because we didn't get enough points from the history. Did you ask about any dystonic posturing?
No, ma'am.
You told one thing, that arm swing is reduced, you told.
Yes, ma'am. And he doesn't have any dystonias, ma'am. He doesn't
indicate. What is the, why you should have arm swinging while you are walking? Why do you swing your arms? With the opposite, suppose that it's a arm. Like that, move forward when moving the right leg. So it is like that. So what is the term used for this movement when you are walking with your leg? Why should the arm have a movement? These are called synkinetic movements.
Okay.
Synkinetic movements. No, there are some movements which are synchronizing with the primary act that is being carried out, even though that body part is not involved in that act. So they are called synkinetic movement. So arm swing while walking is a physiological synkinesis which has got importance in balancing and increasing the speed of walking. So you said that your patient has got a decreased arm swing, and so probably there is failure of synkinetic movement. So first thing is a purely motor stiff weakness of limbs. Second, you have got decreased physiological synkinesis of the upper limb, which happens during walking. So physiological synkinesis is usually lost without weakness in extrapyramidal disorder. In pyramidal disorder also it will be lost, but it will be associated with weakness. Whereas patient is not complaining of anything, and when he is walking, people are observing he is not moving one leg. That means it is extrapyramidal, where the physiological synkinesis, which is important for balancing while walking, is lost. So that may point to extrapyramidal. You can tell that my patient did not complain of any weakness of the upper limb, but the family members notice that he is not swinging his arm. So there is loss of physiological synkinesis, which indicate that his balancing is probably poor. Next, you said that he is having syncopal attack.
Yes,
so would you like to describe that syncopal attack? Syncope means there is sudden loss of consciousness.
Yes, ma'am.
So he has a loss of consciousness. So how many times he had, and what were the accompaniments of his syncopal attack? His syncope maybe, it can be due to a loss of consciousness, could be seizures or syncope. So you should ask whether he had seizure associated with that. No, the biggest seizures are the commonest cause for loss of consciousness. So it was not there. So
No.
he's an old person.
Yes.
So you have to ask for what all things, whether he had a stroke Adam attack. He's a 60-year-old person. So whether he had a stroke Adam attack. So stroke Adam attacks, they will have asystole, transient asystole. That is why they get that loss of consciousness. So those people have pallor to flushing. During that, you have to ask the observer to describe. So if they have examined, he will be pulseless. But if they are not examining, you'll find extremely papery pale, followed by immediate flushing. The rhythm changes. That is why patient gets up. So is it a stroke Adam attack? Common causes for syncope. One is a stroke Adam attack. Second, did you have a reflex syncope? You have got micturition syncope, you have got cough syncope, you have defecation syncope, or even sudden laughter can produce syncope. So you have to ask, what is it that preceded the syncope? Is it a burst of cough, or is it a micturition, or is it micturition? Usually when they are getting up from deep sleep and go and pass urine, they fall down and get head injury. That is micturition syncope. And the treatment for that is different, not with anticonvulsant or anything like that. So what preceded? Is it a
Ma'am,
cough syncope?
when he's walking, he's suddenly falling down, ma'am. He doesn't have loss of consciousness, but just he's falling down, ma'am. That's it.
In that
When
case,
he's
you should not use the term syncope, because
okay.
repeatedly you told syncope.
Yes, ma'am.
Syncope is different from fall. Syncope is there means syncope means there is loss of consciousness.
Okay.
So you repeatedly told syncope. So that is why syncope may be stroke alarm attacks. It can be reflex syncope, or it can be due to postural hypotension, in which situation patient will tell that when he is standing, he feels graying of vision, he feels dizzy, and then he faints. That is autonomic. In the early stages, when they take hot water bath, they faint. It is not due to hot water epilepsy, but when you take a hot water bath, there is flushing. When there is flushing, already decompensated autonomic system becomes severely decompensated. So patient will faint. So early induced flushing and fainting could be hot water epilepsy, or it could be autonomic. Hot water epilepsy manifests very young. It happens in many members in the family, and not at 60 years. So that is orthostatic hypotension. So is it stroke alarm, or is it a reflex syncope, or is it an autonomic dysfunction, or does he have any chromaffin tissue tumors, like organ of sugar candle in the bifurcation of aorta, or suprarenal tumors? They release biogenic amines, jugular body syndrome. When they release biogenic amines, patient will have flushing first. Unlike stroke alarm, there is pallor followed by flushing, whereas in chromaffin tissue tumors, patients experience palpitation, flushing because of the biogenic amines, then they faint. So he flushed and he fainted means it is a chromaffin tissue tumor. You have to search for in the jugular body, suprarenal bifurcation of the aorta.
Okay.
Then next other causes for syncope, you have to look for, or you may have seizures resembling syncope. So if it is when you tell or it can be even vasovagal syncope, which happens very occasionally, once in a way, during painful situations, following blood or some alarming situation, he sees and he faints. So you should ask, if there is no loss of consciousness, it is not at all syncope. So if you did not have loss of consciousness, don't call it a syncope. Then it becomes a fall. So it's a fall. Patient had repeated falls while walking. So if it is a fall, again you have to describe it from a different angle. So falling patient with loss of consciousness, without loss of consciousness. With loss of consciousness is seizure versus syncope. Without loss of consciousness, you ask with vertigo, without vertigo. Because with vertigo, you can fall due to vertebrobasilar insufficiency. 60-year-old person has vertigo, brainstem ischemia, and he faints. So it is with vertigo, maybe vertebrobasilar insufficiency. Second, you can have autolytic crisis of Tumarkin. That is Meniere's disease patients can sometimes go into severe endolymph blockage and accumulation of fluid when the patient will be thrown to the floor. He will not be losing consciousness, but he will feel like that. It is severe. He is thrown to the floor. He continuously vomits. And unlike vertebrobasilar insufficiency, where when the patient gets up, he is left with a lot of sequelae, these people get up and walk. And then you ask them, he will say, I am having deafness, some tinnitus, fullness in the ear. Quite some time, my family members also have it. That is autolytic crisis of Tumarkin or Tumarkin's crisis. Then you can have it in vestibular neuronitis, viral labyrinthitis. All these conditions you can get vertigo and loss of consciousness. So vertigo and fall without vertigo. Fall without vertigo, you ask whether it is a buckling and falling. But we are thinking whether it is pyramidal or extrapyramidal. We don't know, no, because we didn't get the finer points which we wanted to get in the history. So buckling and falling can be pyramidal, or it can be due to LMN or due to joint problem. Joint problem is disorder of cruciate ligament, semilunar cartilages. When they are damaged due to any cause, the joint disease, they will have painful buckling, very common in obese females. in this age group, when they have cruciate ligament dysfunction, they will have painful buckling. There will be swelling of the joints. So that is a cruciate ligament dysfunction or semilunar cartilage dysfunction. That is painful buckling. If it is a painless buckling, it's a flail buckling or a stiff buckling. Flail buckling happens in quadriceps weakness. Then the nerve supply to the quadriceps, that is femoral nerve. Then the root supply to the quadriceps, that is L3 root. That is a flail buckling. So it may be muscle, it may be nerve supply to the muscle, it may be root supply to the muscle, or it can be an anterior horn cell disease starting in the lower limb.
Okay.
So that is a flail buckling. If it is a stiff buckling, usually it is a pyramidal buckling. Pyramidal buckling, and rarely it can be hydrocephalic buckling. So if it is buckling and falling, pyramidal buckling is because of loss of kinetic melody again. There is co-contraction of agonist and antagonist followed by co-relaxation. Normally agonist will contract and the antagonist will relax. That mechanism is called kinetic melody. Agonist will contract, antagonist will relax, synergist and fixator will assist. That is kinetic melody or the music of a motor activity. So when this pyramidal system is diseased, kinetic melody is lost. So there is co-contraction of everything, agonist, antagonist, synergist and fixator followed by co-relaxation. So stiff buckling can be pyramidal. Then hydrocephalic buckling, you know these conditions called colloid cyst of the third ventricle. When it is a pedungulated tumor, it can intermittently obstruct the aqueduct and dilate the frontal horn. So when the frontal horn dilates, the leg fibers are in the interhemispheric region. So it will compress on the leg fiber, patient will fall. They can have small incontinence sometimes, and they can sometimes have a brief period of unawareness, and they get up, and that is hydrocephalic buckling. So if it is a stiff buckling, it could be pyramidal disease or it could be hydrocephalic attack. So your patient is not buckling and falling. Next you have to ask whether he is having drop attacks. Old people have drop attacks. There is something called drop attack. Drop attack is sudden loss of postural tone with immediate writing. So they just fall down and they get up and walk. That is a drop attack. Drop attack commonly occurs due to top of the basilar syndrome when there is a crus cerebri ischemia. The motor tract in the crus cerebri becomes ischemic. After repeated attack, they may go into vertebrobasilar stroke. So that is one cause for drop attack, and there is idiopathic drop attack of elderly, where there is retained consciousness, sudden loss of postural tone, and they get up. Next, you have got cataplexy. That doesn't start in the 60 years, usually starts much younger. They learn narcolepsy if you question, and they may have hypnagogic hallucinations, sleep paralysis. So narcolepsy, cataplexy syndrome, patient might complain only about the fall. But yeah, because sleeping in the class is not considered a good thing. So they will not tell about paralysis also, they will not tell. They will tell, think that some devil or something. They feel paralyzed.
He said that.
The history, what did he say?
He had difficulty in eating, ma'am, and mixing the food, and he had difficulty in slowness in wearing the food.
No, we are discussing the faults now. See, next symptom is the faults. No, and eating comes later. You told about the faults and you called it as a syncope. That symptom I am discussing. It is not a syncope straight away. We have knocked out because in our lost consciousness. Now, why is he falling? You forgot. You are losing track of what I am telling.
No, ma'am. No, ma'am.
Because only 1 hour and my mother is sick. So I am telling everything myself. See, did you understand why your patient is falling? Why you went away to eating?
He while performing his activities.
Tell me why your patient is falling. It is clearly not syncope.
Yes, ma'am.
No, he has no buckling and falling.
Yes, ma'am.
He has no cataplexy. He has no drop attack. He has no vertebral vertigo.
Yes, ma'am. Yes, ma'am.
So it's a, why is he falling? Then you have to ask, is he reeling and falling? Is he swaying and falling? Is he falling forward? Is he falling backwards? Or is it a multi-directional sudden falls? So to analyze the symptom of fall,
Yes,
I
ma'am.
am teaching you.
Yes, ma'am.
You are cutting me halfway. That means you slept off. I
No.
think so. You see, you have not analyzed the fall. No, you concluded it is syncope. It is not at all syncope.
Yes, ma'am.
It is not at all syncope. You concluded. So I am trying to teach you that
Yes.
it is not syncope. So is it a painful buckling due to joint disease? You did not elaborate at all. You just told syncope, which is not at all there.
Yes, ma'am.
Understood? So
Yes,
a falling patient, how to analyze? That is what I am telling you.
Yes.
A falling patient should be analyzed as with loss of consciousness or without loss of consciousness. With loss of consciousness may be syncope or seizures. Without loss of consciousness, with vertigo, without vertigo. With vertigo, I told vertebrobasilar and vestibular system and its connection. Without vertigo may be painful joint disease, or it may be buckling and falling due to LM and or UMN causes, including hydrocephalus. Or it could be drop attack, it could be cataplexy attacks. None of those things are there means then you have to go next further and ask whether he is swaying and falling. Swaying and falling will be cerebellar. You see, falling forwards or backwards, it will be Parkinsonian, pulsion, propulsion, retropulsion, either forward or backward. Or if he is falling sudden in multiple directions, he doesn't know why he fell. And initially when you examine, nothing will be there. These people get their joints replaced. That is pedunculopontine oscillator complex. So multi-directional, unwarranted, sudden falls, which patient does not know why. That is pedunculopontine oscillator complex or the pedunculopontine nucleus.
Okay.
So like that you have to tell, you did not elaborate. So I am teaching you, next time you see a falling patient, when there is no loss of consciousness, kindly do not call it as a syncope or a seizure. Try to analyze like this. A patient, you cannot conclude the diagnosis and fix everything into that head. Instead, one patient can have multiple problems. You have to analyze properly. So you have to tell all this and finally say why your patient fell. Did he fall forward? Did he fall backward? Did he sway and fall? Did he reel and fall? Or is it a multi-directional fall with immediate righting and nothing was abnormal at that time? So you told that he's having stiffness, reduced armsing. So this patient is expected to fall forward or backward. You see, to catch the center of gravity with an abnormal posture, they may fall forward. Sometimes they can
fall, ma'am.
So if it is a multi-directional fall, you have to put the pathology in the pedunculopontine nucleus. The pedunculopontine nucleus, they most often they fall backwards, but they can fall in any direction. And they suddenly fall and they get up. And initially the examination may be normal. And later during the course of the disease, he may get many of the symptoms. So if it is a multi-directional fall, you have to call it as a pedunculopontine nucleus. Probably there is a pathology in the pedunculopontine nucleus. First thing you told, reduce armsing and stiffness. So it is probably extrapyramidal. Second, there is a PPN involvement. But did you understand what I am trying to tell you? You see, you should never call this as a syncope.
Yes, yes.
And a falling patient, you have to analyze properly. And you see what prevents this person from having an osteoarthritis and joint dysfunction. Then you will not treat a pedunculopontine nucleus, which is not there. Joint disease is very easy to treat.
Yes, ma'am.
So you cannot say that my patient does not have a cruciate ligament dysfunction without asking for that, without asking the correct history. So you have to go through this exercise so that you get the correct problem. One patient can have more than one problem. It is not necessary that they have got only one. Most of the time you should try to fit into one diagnosis. But common problems are common and you should ask for that history. So multi-directional painless falls with retained consciousness can be pedunculopontine oscillator complex. Another differential diagnosis, drop attack, but that is not multi-directional. They have sudden loss of postural tone with immediate righting. So drop attack is defined as sudden loss of postural tone with immediate righting and retained consciousness. Sudden loss of postural tone with immediate righting. That is, he writes himself and retain consciousness. That is a drop attack. Whereas epidangulo-pontine complex, generally they fall backwards, but they can have sudden unwarranted multi-directional falls from which they get up. They are conscious, and in the early stages they will be able to demonstrate why he is falling, and an innocuous joint will be blamed, and they operate on those things. So that is epidangulo-pontine complex. Next symptom, he has difficulty in walking since here, like initiating to walk and taking short steps while walking, and difficulty in taking turns while walking. So you analyze that symptom. Analyze. Initiating anti-gravity stretch, stepping, propulsion, equilibrium. So you have got anti-gravity stretch. You have got stepping. Then you have got equilibrium. Then you have got propulsion. These are the 4 phases in walking. Neurological patients have these 4 phases. Anti-gravity stretch. You said that he has difficulty in initiating to walk.
Yes, ma'am.
Initiating to walk means he has difficulty in lifting the leg from the floor.
Yes, ma'am.
So that is anti-gravity stretch. So would you like to elaborate that? It can be an apraxic limb. So difficulty in lifting the foot from the floor can be apraxia. Apraxia will be, so you have to elaborate that so that we know whether your patient has got apraxia or something else. So apraxia will be patient feels that is glued to the floor. And once you make the patient, help him by lifting his foot and putting it forward, then he walks normally. So gait apraxia is patient will be moving the trunk forward, and he will tell the magnetic field of the earth is pulling my leg. Like that one patient has described to me, or in the textbook it is described that to the floor. But once it is initiated, he walks much better until in the late course of the disease. So here you have got a patient who has difficulty in initiating walking. So whether it is apraxia. Second, any other situation where you can have gait initiation defect, you can have ignition failure, that is extrapyramidal. So patient will make multiple short steps. So in the same place, he will make multiple short steps before he proceeds further. That is called ignition failure. So is it an apraxia, or is it an ignition failure, or is it a stiff leg due to pyramidal tract where the normal heel first gait is changed over to toe first? So he finds difficult, and the toe strikes the floor, so he tries to circumvent. So you have to describe, or does he have freezing? So they can have apraxia, they can have freezing episodes, they can have ignition failure, or they can have pyramidal type of spasticity with a semiology changing over to toe first gait, because of which patient is not able to move forward. So what is the thing that is in initiating walking? So initiating walking, you have to tell me now, does he feel the Earth's magnetic field is pulling his feet, or does he have repeated starts, that is called start hesitation or ignition failure? Does he feel frozen while starting his gaiting, freezing gait, or does he have a toe first gait due to spasticity? So that we will.
He has a spasticity, and he also has a freezing, ma'am.
Am I audible or not?
Yes, ma'am. Yes, ma'am.
Then you tell me. What did he say?
He has spasticity while walking, ma'am.
How do you know it is spasticity? Because you have got some tendency to make conclusion without describing. That is what happened in the falls also. You concluded it is syncope when it is not syncope at all. And without knowing any evidence for spasticity, you are telling he is a spastic gait. So why did you conclude it is a spastic gait? That habit you have to change, because you graduate and you are going to be a teacher. No. So you should learn correctly. You should not draw conclusion without description. So first thing you went wrong. You are very clearly, have you understood? It was not at all syncope. You concluded it is syncope. Now without giving any evidence for spasticity, now we are telling that your patient, in addition to extrapyramidal, is also having pyramidal disease. So what are the evidence for the pyramidal problem in your patient's gait initiation? Did he have a pyramidal foot drop? Did he have a circumduction gait? Did he have a pyramidal pattern? No.
No.
Then you should not call it as spasticity. Never tell the conclusion in the history. Conclusion comes in the discussion. You should describe. History should be description. That is the most vital part of neurological examination. Otherwise, you'll be 100% wrong. You had slowness, you had decreased arm swing, and you can have a patient who has got a spasticity. In addition, the diagnosis will be, each one will be one group. So if you are telling spasticity, you are recruiting another tract, that is a corticospinal tract. So if it is a corticospinal tract involvement, the gait initiation defect will be from the normal heel first gait, patient shifts to a toe first gait because of the pyramidal foot drop. To avoid injury to the toes, he will circumdent. So you should say, my patient has got a toe first gait, it is stiff and he is circumducting and he is keeping his arms in flexion. So I am thinking it is spasticity. Instead, without describing anything, initiation difficulty and I think spasticity, no. You should get out of these symptoms sufficiently early. Otherwise, it will become our habit and we may make many major mistakes. Always observe, describe, and then draw conclusion. So understand, if here nothing is there to tell it is a spastic gait. Does he have a toe first gait? Does he have circumduction?
No.
Pyramidal pattern? No. So it's not spastic. You are not asked the exact problem in initiating to walk. That's okay. So I have told you the points. Keep it in your mind. And when we see the next patient, you ask so that we will be much faster in drawing conclusions. You told next is a short step. Short steps is called as what? So anti-gravity stretch part is abnormal. But what exactly is abnormal? You have not elicited the history, so we do not know. So we'll keep it like that. Second, stepping. Stepping means anti-gravity stretch is stepping, equilibrium, propulsion. This is a 4. Stepping means when he flexes one leg, the opposite leg will extend. It goes on in an alternating fashion. So is he able to do that? Does he do alternate? So you're not. So okay, so stepping part we do not know. We'll keep it like that. Then you have got equilibrium. Is he swaying or reeling? No. That's all right. No, then you have got propulsion. So during propulsion phase, you have got something called stance, pace, turns. Pace is the space covered between 2 feet during stable walking. So a short steps is a short span. So your patient has got a gait initiation defect and he has got a reduced pace. Pace is the distance covered between 2 feet during stable walking. So the distance covered between 2 feet during stable walking is reduced. So pace is reduced. That is called festinating gait. So you have got 2 phases in your patient affected. One is the anti-gravity stretch. Second is the propulsion. In between, what happens, stepping and equilibrium may be normal, we don't know. So that means probably he has a short hesitation. Usually patients who are festinating have a frontal gait disorder. They have gait initiation defect because you are not asked detailed history, we'll presume like that. So festinating gait with a gait initiation goes into a frontal gait or extrapyramidal gait. And then you have got difficulty during turns. So what is the difficulty? Does he turn like N block, or while he is turning, does he losing balance, or is he swaying? During turns, you can sway. In cerebellar disease, swaying becomes more manifest during turns. And in extrapyramidal disease, they turn like a log of wood, or during turns, they topple and fall. Your patient is already falling. So they may topple and fall, or they may turn like a log of wood. That goes to extrapyramidal, whereas swaying during turns is cerebellar. So you have initiation defect, you have got short steps, you have got turns difficulty. Further elaboration is not there, but it apparently appears that probably your patient has got a start hesitation with festination and trunk balance. So he is having imbalance during turning. Then climbing up more than getting down from stairs. So difficult in climbing stairs more than getting down. So climbing stairs more difficult than getting down means what exactly you have to describe. Is he losing balance, or is he having a difficulty in hip dip is there, or does he put one leg on the step above with the hand? Otherwise, it has no meaning. So climbing stairs more than getting down means usually it is a proximal muscle weakness. So you should ask that history. When he is putting the one foot on the step above, does he have a hip dip, or does he have this Trendelenburg effect, or has he to put his leg on the step above using his hand? So if that is there, this is very relevant, because in element disease, climbing up is more difficult than climbing down. And in climbing down is more difficult in lumbar canal stenosis. Climbing up and down is equally difficult in corticospinal tract disease. Instead, if you say difficulty in climbing, does he have a stiff back? In this patient, I am expecting a stiff back, because of which he is unable to climb. That you should be telling. That you should be telling. Then the interpretation is going to be entirely different, because I told you how to differentiate pyramidal from extrapyramidal. Extrapyramidal will be due to slowness or rigidity, so it will be more proximal. They present with low back ache or periarthritis or cervical spondylosis like symptom. So you can say my patient has got climbing up difficulty due to a stiff back. You should, if you tell that, it becomes, it is a akinetogenic syndrome. Otherwise, we will have to elaborate on muscle and root diseases, which we have discussed many times in the past. Then history of loss of arm swing. Okay, that is synkinetic movement is reduced. Difficulty in getting up from the bed since 3 months. What exactly is the difficulty? You have to explain. Is it a posture maintenance problem? Does he feel stiff and the body looks like a log of wood, and he maintains postures in odd position? That we call as psychic pillow sign. When you get up, a person like this might get up like a log of wood. He will be extremely slow. Midway through this process of getting up, he may stand arrested like that. That we call it as a psychic pillow sign. They will opt odd postures, maintain like that, as if they have kept psychological pillows along behind their back of the head or the trunk. So that is called psychic pillow sign. So when getting up, so you should avoid using this difficulty. Everybody has got difficulty. Some people are very lazy, so they want to sleep. So they will not get up from the bed. So the difficulty word should be erased. And you should tell, while getting up from the bed, my patient consumes lot of time. That means, he is bradykinetic, he is very slow. And midway through his postures, he stays in those postures, and he moves like a log of wood. If you say, we will know that this is a extrapyramidal disorder. Or if your patient says he is unable to turn in the bed this side or that side, he is flail and he has to be supported and lifted, he is not stiff or he is not slow, then you know that it may be a muscle disease. Paraspinal muscles, abdominal muscles may be weak, neck muscles may be weak. So you have to elaborate what exactly is the problem. So in this case, I presume that he gets up slowly, he moves like a log of wood, and he has to be supported, and he may be up keeping odd postures. That is, all these difficulties should be removed. Difficulty is a nonsensical word, it does not convey any meaning. What is your patient's problem? You have to ask repeated questions and gather them. And no syncopal attacks, so you have put syncope, that completely delete it off. Then history of recurrent falls, that I agree. And 15 days back, okay. And a tingling sensation in the right upper limb and right lower limbs in 6 months. So what is the tingling sensation? When did it start? What is the distribution? So tingling sensation is what?
It's in hands and feet, ma'am. Distal more than proximal, ma'am. Just is having continuous tingling sensation in since 6 months, ma'am.
You see, tingling sensation.
No burning sensation, ma'am. No radiating pain.
So if there is a tingling sensation, what do you call that? You call it as a paresthesia.
Yes, ma'am. Paresthesia.
So paresthesia is sensory perception in the absence of sensory stimuli. So paresthesia. So depending on the distribution of the paresthesia, it usually comes from the large fiber disease. And so now first symptom is a paresthesia, and it is a large fiber disease. And based on the distribution, it can be nerve, it can be root, it can be tract, or it can be cortex. See, but you are telling it is on one half and one upper limb and one lower limb. So whether it is a cortical, we don't know. You have got classically in one condition paresthesias which are evasive in the distal parts of the limbs in one half of the body. Later it is displaced by alien hands, useless hands, no, and myoclonus. So whether it is that. Otherwise, if it is not in the distribution of a nerve, it is not in the distribution of a root, so it is not in the distribution of a tract. So which tract? Posterior column. So tingling paresthesia may be proprioceptive fiber in the lower motor neuron, peripheral neuropathy. Diabetic patients commonly, no, they will have tingling sensation. So paresthesia is spontaneous sensation in the absence of sensory stimulus. It is due to uninhibited small fiber activity due to disease of the irritative disease of the small fiber or destructive disease of the large fiber. That is how you describe paresthesia. So it is not in the nerve distribution. So it is not a neuropathy. It is not in the root distribution. It's not a radiculopathy. So if it is a tract, we are expecting alarmate sign, lightning pains, girdle sensation, and a bizarre pattern of deep boring paresthesias in the limb. So it is not in the tract pattern. You told that it is in the distal part of the hands and the feet. So is it a cortical dysesthesia, considering the way this patient is progressing with some kind of axial rigidity, falls? This is followed by an asymmetrical paresthesia. So it may go into a corticobasal degenerations. So because you are telling it is distal and it is not respecting any of this distribution, I will consider the possibility of a cortical paresthesia. Okay, next. What is the next symptom? That's all?
He has
So now you have said that your patient has got a stiffness and he has got a tendency to fall in multiple directions. He has decreased arm swing and he is having sensory paresthesias in one upper limb and one lower limb. Then you said that he has double vision. Would you like to describe the double vision?
Ma'am, only double vision of far objects, ma'am, and he had blurring of vision of both eyes since 2 years, and left eye he operated for cataract 2 years ago, ma'am. Still he has blurring of vision, and when the both objects of in double vision.
Is it a horizontal double vision? Is it a vertical double vision? Is it a uniocular or binocular?
Binocular double vision, ma'am. Binocular double vision.
So when you close one eye, is it disappearing?
No, ma'am.
You see, binocular double vision means it is a neuroparalytic. It may be third cranial nerve, fourth cranial nerve, or sixth cranial nerve. So binocular double vision will disappear when one eye is closed. That indicates it is not psychogenic or it is not due to an ocular cause, not due to sometimes cataract, post-traumatic cataracts, or some lesions in the retina, anterior visual pathway problems can produce some uniocular double vision, cornea, corneal pathology, lenticular pathology, retinal pathology can sometimes produce uniocular double vision. Otherwise, the commonest cause for uniocular double vision is psychogenic. So binocular double vision means the double vision is there when the patient is seeing with both eyes. And when patient is closing one eye, the double vision is disappearing. That is typically 3, 4, 6 cranial nerves.
Yes.
Neuroparalytic double vision will be binocular and it will disappear when one eye is closed. And distant object double vision is usually lateral rectus. But you have to get lot of information on this double vision, whether it is really there. He had undergone cataract surgery. So does he have an after cataract? So even when he closes the right eye, the operated eye continues to show double vision, means it solves the problem.
Yes.
That is what I am expecting. I think you have not gone into the history properly. So binocular double vision means you should close one eye and disappears. So I think you didn't understand. So it is, I am not sure it is a binocular double vision. In this case, it could be due to after cataract. It can be an ocular cause. So you have to carefully examine whether he is having double vision with the left eye. Even when the right eye is closed, the double vision is there or not. That is what you have to ask. Otherwise, you are going to put a lower motor neuron pathology there, which I am not thinking is there in this case. You have to analyze that. You have to go through the case once again and ask. Poor vision can happen due to impaired eye movements, which will not improve with cataract surgery. When the eye movements are slow, the vision will be poor because of fixation defect is there, so vision will appear poor. Even though cataract might have been there and cataract has been operated, patient does not improve in vision, then usually it is a retinal macular pathology or they have got eye movement problem. So if there is eye movement problem, the vision does not improve after cataract surgery. Or if he has a maculopathy, he will not improve. If he has a retinopathy, he will not improve. So these are the causes, but double vision, I think you have to go through the symptom once again, examine the patient properly. And is it horizontal, vertical, uniocular, binocular? All those things you have to ask. Okay. Then next. No salivation, no ingurgitating, no difficulty swallowing, drinking. Okay. Then no history of swaying while walking. Anything else? It's all. So from the history, it is a stiff lower limb with repeated faults and poor vision, which is not improving after cataract surgery. Double vision, you have to evaluate little more depth. Okay. Next, on examination. And he has got some sensory features. So, yes, the sensory features, if they are correct, does he have any myoclonic jacks? Does he have alien hand-like phenomena, abnormal levitation, abnormal posturing at the right? All those leading questions you will have to ask. So, extrapyramidal features, repeated faults, REM sleep behavioral disorder with sensory loss, myoclonus typically seen in corticobasal ganglia degeneration. Okay.
6 months ago, he had an episode of slurring of speech and deviation of mouth to left, ma'am.
Okay. Did it improve or not?
Now it improved, ma'am. Now he doesn't have any symptoms, ma'am.
What do you think it could be? Maybe he had a TIA.
Yes,
maybe he had a transient ischemic attack.
yes,
Okay. Next. Okay. Examine the patient. On examination.
On examination, he is right-handed, ma'am, and is conscious, coherent, and cooperative, comfortable lying on bed, and patient is well-built and moderately nourished, has no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema, no neurocutaneous markers of tuberculosis, leprosy, or hyperlipidemia, and his vital data, temperature is 98 degrees Fahrenheit and
tuberculosis and all you need not tell in this case. I don't think it is relevant. Okay.
Okay. In nervous system examination, patient is right-handed and his GCS is 15 by 15. His memory, immediate, recent, and remote memory are intact. Intelligence is normal, ma'am. No delusions
Okay.
or
Go
hallucinations. His speech and MMS score is illiterate, ma'am. So 19 by 13.
Okay.
And cranial nerves, first cranial nerve is normal, ma'am. Second, visual acuity is decreased, ma'am. Counting fingers at 4 meters distance in both eyes. And visual field decreased superiorly, ma'am. Pupils and third, fourth, sixth cranial nerves, ma'am. He has a restricted upward gaze, ma'am.
Okay.
Restricted upward gaze. All other gaze movements are also restricted, but more in the upward, ma'am.
Okay.
And no nystagmus, ma'am. No light reflex is normal. Accommodation reflex is normal. No ptosis, ma'am. And fifth cranial nerve, sensations are decreased on right side of the face, ma'am. And seventh cranial nerve is normal, ma'am. Eighth, ninth, all other cranial nerves are normal, ma'am.
Okay.
Motor system, all the parameters are normal, ma'am. Power, arm circumference, all those are bulk is normal, ma'am. Power is normal, and tone is increased in all the limbs, ma'am.
Okay.
And reflexes, superficial reflexes are normal, ma'am. Deep tendon reflexes are exaggerated, ma'am.
Okay.
Biceps, triceps, and tripod all both sides 3+, ma'am.
Okay.
And sensory system, right side, all the pain, temperature, touch, vibration, and joint position all are decreased, ma'am.
Okay.
And coordination is normal, ma'am. Glabellar tap is present. No other cerebellar signs or meningeal signs, ma'am. And patient.
So what do you see in his face? So I agree that his field impairment may be due to the restricted upgaze. He has a stare.
Yes,
You can see the stare in his eye, no? The upper eyelid is elevated. That is called as Collier sign. COLLIERS, Collier sign, that indicates posterior commissure involvement. He has a surprised look. That is called a Collier sign. It is due to posterior commissure involvement. See, and upgaze restriction will explain restricted field in the upper part of the eye, not due to field defect, not an altitudinal hemianopia, but it is due to restricted eye movement. And you said mild vertical diplopia, that can happen in the early stage of vertical gaze palsy. Somebody might feel a blurred vision and they may call it as a double vision. So all those things we can agree. And now the sensory loss in the upper limbs and the lower limb is not distal, not cortical. Initially, in the history, you told it is a distal tingling paresthesia. So we thought about possibility of CBD. But after examination, it is all modalities in one half of the body. So that we will dissociate. So what is common is the stare in the eye, repeated falls, upward movement restriction, axial rigidity, and appendicular rigidity, lower limb onset. This will go classically into PSP syndrome. So he's having a stare, that is a Collier sign. So many other signs you'll have to look for. There is something called Procerious sign, where the forehead will have these vertical grooves. And when they get up like a rocket, no? The trunk moving like that. And applause sign. You tell the person to clap the hands, and every time you clap and you stop, he has to stop. But he will not stop. He will keep on clapping. That is called applause sign. So eye is diagnostic in this patient. He has a stare, he has upgaze palsy, he has repeated falls, and he has got rigidity that goes into PSP syndrome, progressive supranuclear paralysis. But what is odd is the right hemisensory impairment and a brief episode of deviation of the angle of the mouth to one side. That indicates that he has a dual pathology. Probably he had a vascular disease, a lacunar stroke, which has left a hemisensory loss. So it's a dual pathology. These two cannot be explained. Sensory in extrapyramidal disorder is cortical sensory loss with the stimulus sensitive myoclonus, abnormal posturing. That happens in corticobasal ganglion degeneration. Whereas hemisensory loss, facial deviation, all this will go with the vascular event. So my patient has got a dual pathology. One is a PSP syndrome with a lacunar stroke, leaving sequelae of hemisensory loss on the right side. So that is my diagnosis. What did you examine? What did you do? See in the MRI?
Hummingbird sign is present, ma'am, on MRI.
Did you see any lacune in the internal capsule? Posterior limb of the internal capsule or thalamus? Could you magnify that? So let me see the hummingbird. Where is the sagittal cuts? These cuts are too small for me to see. Is it possible to expand this? Magnify, is it possible? I am not able to see the images properly. Yes, it is. If you can expand that, I can see. Is it possible to expand these cuts?
Yes, ma'am, I'll try.
You can just zoom it in the view this way.
The sagittal cut, you are respecting a hummingbird, but I am not able to see it properly. And morning glory sign you will find in the axial cuts. That also I am not seeing.
Ma'am, I've zoomed.
Oh, okay. It is not completely this thing. Here you see a good volume for the midbrain. Here it looks like midbrain atrophy. Pons appears prominent, that is called pregnant pons sign. That's also seen in PSP only. So more prominent pons, and then there is a ratio between the ratio of the midbrain to the ratio of the pons. That also you can look for. Classical hummingbird, here you see some good midbrain volume. Does he have any lacune? I want to see the axial cut. Can you show the axial cut? Can you show the axial cuts? Clinically, it is definitely PSP syndrome. The classical scare is there. Stare is there. There's a Collier sign is there. The faults are there. Typically, it is a PSP only. Plus, there is a vascular insult, definitely. So to look for, can you show me the other cuts to see a lacune in the internal capsule? It's not there, huh? The left internal capsule. Okay, it is no visible infarct is there, but the strictly focal, all modalities impaired with a transient facial deviation has to be a vascular pathology. So you'll have to investigate your patient for vascular risk factors which can add to his problem and you can prevent them progressing at least. And PSP syndrome is very difficult to treat. You should not use any dopa agonist. It will not work. You'll have to use only dopa. And the faults are treated with solpidem. Solpidem is used in treatment of faults.
Okay.
And head injury and fractures, those should be prevented by non-pharmacological methods also. And Sindapa might get for some help for some time. Okay. So, but you did not describe the right hemisensory loss, no? You cannot leave it after describing, or you should say that my patient's hemisensory loss, I do not believe. You told that you had a facial deviation also, no?
Yes, ma'am. Yes, ma'am.
So that you cannot leave off.
Okay.
You should describe everything. Okay, you only said no. He had a history of facial deviation and he is left with hemisensory loss. That you should not forget in the final diagnosis.
Okay.
So he has a dual pathology. The staring one is the PSP, and he definitely has got a vascular thing. So I have to do a carotid Doppler, cholesterol, cardiac evaluation. So that part you can prevent from progressing. And okay, the hummingbird is not very classical. You can call it as a pregnant pond sign. Ponds appears more prominent.
Okay.
Okay. Any doubt is there?
Ma'am, PSP patient will usually have downward gaze palsy, no, ma'am.
No, you see, not like that. Downward gaze palsy, if it is there, it is very, very specific. But commonly, you get only up gaze palsy. Downward gaze palsy is very specific. But sensitivity is up gaze palsy. Up gaze palsy even otherwise occurs in older people. This person is only 60 years. He is not in that age group. And he has visual impairment and he has got cochlear sign. Everything points to a dorsal midbrain involvement, posterior commissure and dorsal midbrain involvement. Down gaze palsy is very, very specific for PSP, but very rarely you see that. It is up gaze palsy that is commonly seen, much more than for his age and more symptomatic than age. Age-related up gaze restriction is asymptomatic. It happens in the 7th or 8th decade and patients do not have restriction of field of vision or they do not have acuity problem. Whereas he is symptomatic, he is young, and up gaze palsy is the commonest in PSP. Even though down gaze palsy is very, very specific. It is less often seen. Okay. Any other question? Any other question?
What are the pointers that indicate that the patient might have a Parkinson plus syndrome?
You see, Parkinsonism plus other parts of the neuroaxis. That is Parkinson plus. So in your patient, the other part of the neuroaxis involvement is lid retraction, eye movement problem. They can have cognitive impairment, but illiterate person 19 cutoff is upper limit of normal. For an illiterate person, 19 is okay, not bad. No? So in this patient, the falls, severe multidirectional falls, the lid retraction and the up gaze palsy. So Parkinson plus means Parkinsonism plus other part of the neuroaxis involvement. So he has enough evidence for involvement of other parts of the neuroaxis, and additionally he has got other part of the neuroaxis in a vascular territory also.
Ma'am, how should we differentiate it from MSA, ma'am?
MSA will have autonomic dysfunction. So they can have ataxia with autonomic, they can have extrapyramidal plus autonomic, and they can have peer autonomic. They generally do not have much eye signs. Their faults are syncopes due to postural hypotension. They are not faults. Your patient does not have syncope. And they do not have lid retraction. They do not have gaze palsies. They have cerebellar or extrapyramidal, always with autonomic. And MRI will show hot cross bund sign if it is MSAC, and if it is MSAP, you will find striatal hyperintensities, posterior striatal hyperintensities. It will not show midbrain atrophy. So neither clinically, not radiologically, it is MSA, it is PSP only.
Okay.
Any other question? That's all. Sorry, I am in a hurry because my mother is very ill. That's why I hurried. I am really sorry. By the next class, I think my mother will be all right, and then we'll discuss more elaborately.
Thank you so much,
Maybe
ma'am.
I hurried. Maybe I
Amidst
hurried.
your busy time, also you are spending time with us, ma'am. It's a great blessing for us. We are very privileged.
Thank you so much. Thank you very much.
Thank you so much, ma'am.
Thank you.
We all will pray for your mother's health.
Thank you.
Soon,
thank you. Thank you so much. Okay.
Thank you so much.